A view for everyone.
So as you've seen in Potter and Harry, pages
Potter and
432 to
Harry.
699, we're talking about agonist-antagonist actions, and this is really what we're talking about here is the inability to be able to do anything in the cell itself because of the fact that this is actually stopping what's going on with this effect here, really.
This is like some of my biology classes.
Do you understand what we're doing?
No.
What is he even talking about?
Something about Harry Potter or something.
Hey, how's it going? Pretty good. How's class?
Well, we just got out of pharmacology with Professor Howard. You know
Oh, I had him.
Yeah.
What are y'all talking about?
We're talking about receptors, agonists, and antagonists, but I don't know anything about what he's talking about. We were completely lost. I lost him about 2 minutes after class started.
You know what? I know a better way to explain it to you.
Do you?
Yeah. Come and I'll show it to you.
Receptors are any compound, typically a protein, within the body that a drug or hormone can bind to and cause an effect within a cell. The most common example is a protein embedded in a cell wall. If this wall is a cell wall, the socket represents a receptor. Until a drug or hormone plugs in, there can be no reaction.
This is a better example than Locke.
When a drug or hormone agonist plugs into the receptor, a cellular reaction can occur.
There's a cellular reaction. Okay, things are happening. They're grooving in the cell.
An antagonist is a substance which plugs into a receptor site without causing a reaction. Antagonists block agonists from producing cellular reactions.
Those light switch covers for
Well, I'm
safety.
just curious, so how would that relate to nursing?
Well, let's say that you have a patient that has hypertension or high blood pressure.
Okay.
What you would want to do is give them a beta blocker, and that's going to block that and bring their blood pressure down. Does that make sense?
Do you think you could show us that one?
I'd love to.
When a beta receptor in the heart is stimulated by an
You guys learned this
agonist,
last year, right?
such as epinephrine, there is an increase in the rate and force of cardiac contractions. A beta blocker antagonist prevents this from occurring.
So does that make sense? How it all goes together?
Yeah, that makes a lot more sense.
Oh, good.
Yeah.
Without care, yeah, I was out of touch.
So they use that a lot, analogy with, I've seen that used for even like kids and Bill Nye and stuff like that. And you do a light switch and you actually have an electric light bulb and it lights up. And that's a chemical reaction. That's what drugs are doing. Okay? All right, where are we at? Ooh, now we're at the exciting world of efficacy. Efficacy. Sounds like a term that an old English prof would use. Efficacy. This class is not efficient. How well a drug produces its effect. Some drugs produce effects exactly as they want to, and some drugs, close. People who know this, street drug users, they know how the efficacy of the drugs they use and which are good, and the ones we give them in hospital, not so good, right? You tell a pot user that Nabilon, which has got THC in it, is the same, they'll tell you, not the same, right? Not the same. So increasing dosages will only increase effects to a certain point. We know that because every drug has a maximum efficacy. Any drug will have a point where it's maximally effective. There's only so many receptors in the body. You can only saturate so many of them, and then it doesn't matter. You could keep shoveling those pills in, but it's not going to do the therapeutic effect. It might do a toxic effect. So we talk about ceiling a lot with a lot of medications. Therapeutic, we've reached a ceiling effect. It can do no more. Talk a lot about that with renal drugs, that you can only give so much Lasix, and if the kidney failure is so significant, it's not going to have the effects that you want it to. We talk about that with bacteria, that some bacteria have developed the ability to block all the receptors, and so they're resistant to antibiotics. Maybe if you combine a bunch of bacteria together, then you can overcome that ceiling effect. So efficacy, and here's an example. If you were to use a drug, I think that's written up in your notes, Suboxone, 16 to 32 milligrams. The ceiling effect is somewhere between that for every person. Okay, we know that if you gave someone 85 milligrams, it wouldn't do the effect that we wanted it to therapeutically. What is it? It's an unusual drug. And we bring this drug in this unit, for example, to help you with agonist-antagonist. This is a combination. Why would you want a partial opioid agonist and an opiate antagonist? Like, wouldn't one sort of block the other? What population would... Maybe, but think what population might you want to use this with? Somebody going through rehab. You want to give them a little bit of a kick, but not too much of a kick. So this is one you might see used in opioid addiction. It's an opioid to prevent withdrawal and an agonist to stop abuse. So they get enough opioid to keep them from going into the withdrawal, but if they take any other drug, it won't have any effect. There's a great one, I forget what it's called for alcohol. I forget what it's called. It's called Antabuse, but it has an actual clinical name where you take it that you can't drink. If you drink, you get violently ill, like alcohol really, yeah. So some drugs produce greater effects than others, we know that. So it's really important to consider that. The goal of the drug therapy is to match the intensity of the drug response to the patient's needs. So the example I give you is furosemide for end-stage renal failure. What does that mean? What is end-stage renal failure? You have to know what that is. What is end-stage? In a way, it's usually longer than that, but it means you're in terminal liver failure, terminal renal failure, not liver. Okay, so your kidneys are basic. You're on a dialysis machine, probably is what you're on. Okay, or you're palliative. So what we found with Lasix is, with renal failure, we found that 20 to 80 milligrams once a day or twice a day is a good dose for people, and you can go up to 600 milligrams a day. They've done studies where you can actually go up to 2,000 milligrams a day, and it doesn't harm people. Lasix has very few side effects, but you need to do a furosemide sensitivity test with people. How much will it do? So what if your kidney isn't functional enough left? So we don't usually give Lasix to people in end-stage renal failure because their kidney can't even do, it's not even able to do any more reabsorption or excretion, right? So you have to start thinking about, so chronic, if you've got acute renal failure, maybe, and you've got some good renal function, but it's damaged, but it's not bad, you could still use Lasix, and it would have an effect, and you titrate the dose up until it had the therapeutic effect you wanted. Pull enough fluid, so you peed enough out, you dealt with your fluid overload. But chronic, they have very little kidney function left. And so, better effective would be to do hemodialysis. We could give them all the Lasix we wanted, but it wouldn't do anything. Even though we know Lasix is effective, you got to look at how it works with the people. So that's efficacy when it speaks to a person. How effective would it be for a person? I think of narcotics with tolerance. I know some people have tolerance, so it doesn't matter how much I give. I have to give them more for it to have efficacy for that individual.